Hi everyone, this is Jeanne E Poole, the editor-in-chief of Heart Rhythm O2 Journal. This is the December 2024 podcast. Today we lead off with the 2024 HRS Perspective on Advancing Workflows for CIED Remote Monitoring by David Slotweiner and the colleagues. We really appreciate the opportunity to publish this document in HRO2. The document has been in the works for several years and led by, as I noted, David Slotweiner, and addresses the challenges we face managing the data generated by CIEDs. A prior obstacle that has largely been overcome was the HRS-led effort to unify standard nomenclature across the industry, approved by the Institute of Electrical and Electronic Engineers. This document discusses administrative burdens placed on clinicians and staff and the integration of data into the electronic health records. The document lays out a framework for the development of technical standards for interoperability, which would enable the smooth communication of CIED data between information technology systems used in clinical practice. Health Level 7 fast healthcare interoperability resources are leveraged, and the authors present a roadmap for the technical committee to guide this endeavor. Critical data exchange points between remote transceivers, electronic health records, and third-party platforms commonly used for CIED patient data management are identified. The objective of this endeavor is to establish bidirectional communication amongst these resources, ensuring the accuracy, timeliness, and accessibility of clinical data for clinicians. The authors also anticipate substantial benefits for both clinical research and administrative efficacy through the implementation of this interoperability framework. This is really a great document, and I hope that the listeners will take the time to read this paper. The next paper comes from our Global Voices section. Global Voices seeks to represent colleagues practicing in disparate global regions, including areas challenged by health resource constraints. The title of this paper is 30-Day Unplanned Readmissions Following Hospitalization for Atrial Fibrillation in a Tertiary Syrian Center, a Real-World Observational Cohort Study by Dr. Ibrahim Antoun and colleagues. The objective of this study was to assess the rate, predictors, and trends of 30-day readmission after index admission for AF in Syria. Adult patients who had an index admission with AF to Latakia Tertiary Center between June 2021 and October 2023 were included. Patients were monitored for readmission occurring 30 days after the index discharge, and data were abstracted from the clinical notes. A total of 661 patients were included in the analysis, of which 282, or 43%, were readmitted to the hospital within 30 days following index admission. Cardiac causes were the most common cause of readmission in 72% of patients, of which 60% were AF-related. Readmitted patients had a higher median age and were less likely to be male. Multivariate analysis identified that older age, female sex, diabetes, and heart failure were associated with a higher likelihood of readmission. Most cardiac readmissions happen during the first 15 days. Now, the results of this study can be compared to an HRO2 published study in 2022 by Courtney Weber and colleagues from Western Australia. This was a paper of almost 23,000 patients who had been admitted for first-time diagnosis of AF and also looked at unplanned 30-day readmission rates. Compared to the Syrian report, only 9.5% of patients were readmitted. Causes of readmission were similar, with the majority being cardiovascular and AF representing overall 31.7% of the patients, coronary events 12%, and heart failure 8.5% being the most frequent causes. This paper is followed by an editorial written by HRO2 Global Voices section editor Uma Srivatsan and highlights the unique challenges in many global regions to overcome social, economic, and political hindrances to healthcare delivery. The next paper title is A Deep Learning Module ECG Approach for Cardiologist-Assisted Adjudication of Atrial Fibrillation and Atrial Flutter Episodes by Quentin Fleury and colleagues. The background of this paper, the authors note that the importance of ECG screening to identify atrial arrhythmias early is important to prevent adverse outcomes, but the massive amount of ECG data can be burdensome. The authors aim to build and evaluate a deep learning modular software using ECG features well known to cardiologists with a user interface that allows cardiologists to adjudicate the results and drive a second deep learning analysis. The ECG library came from 187 recordings, which included 249,419 one-minute samples. They were beat-to-beat annotated and were included as 2 lead Holter strips in a Holter database. The authors built a deep learning algorithm with a modular structure mimicking expert physician ECG interpretation to classify atrial arrhythmias. The deep learning network includes 3 modules: cardiac rhythm regularity, electrical atrial waveform, and raw voltage by time data, and is followed by a decision network and a long-term weighting factor. The algorithm then was validated on an external database. The author's conclusions are as follows. First, a deep learning modular software using ECG features well known to cardiologists provided an excellent overall performance. Second, clinically significant residual errors were most often related to the classification of the atrial arrhythmia type, that is, fibrillation versus flutter. And third, the modular structure of the algorithm helped to edit and correct the artificial intelligence-based first-pass analysis, and this will provide a basis for explainability. The title of the next paper is A Proposed Algorithm for Management of Patients with Left Bundle Branch Block Post-TAVR, 1-Year Follow-Up, by Avia Bar Moshe and colleagues. The background is that TAVR is still associated with a high incidence of conduction abnormalities, particularly new left bundle branch block. The objective of this study sought to assess the clinical outcomes of patients with post-TAVR conduction disorders managed according to a pre-specified, institutionally developed algorithm. The algorithm required all patients with a new left bundle branch block to be in the intensive care unit for 48 hours. The study included 230 patients who developed a new left bundle branch block. 44 patients developed a definitive indication for a pacemaker due to a complete heart block, Mobitz 2, or alternating bundle branch block. Remaining patients were separated into 3 groups. 1, those with a QRS less than 130 milliseconds who were monitored to hospital discharge. 2, those with a QRS between 130 and 160 milliseconds who all underwent electrophysiology studies. And if their HV interval was greater than 65 milliseconds, then they received a permanent pacemaker. The third group was those patients with a QRS interval greater than 160 milliseconds, all of whom received a permanent pacemaker prior to discharge. During 1-year follow-up, only 3 patients required late permanent pacemaker, and only 1 of those had had a new left bundle branch block post-TAVR. There was no difference in mortality or heart failure hospitalizations between the permanent pacemaker group and the not permanent pacemaker groups. Multivariate analysis identified atrial fibrillation, CKD, and pre-TAVR right bundle branch block as independent predictors for permanent pacemaker implantation following TAVR. The next paper is titled Impact of Body Mass Index on In-Hospital Outcomes in Patients Receiving Leadless Pacemakers, a 5-category analysis. The objective of this study was to explore the impact of BMI on in-hospital outcomes for patients receiving leadless permanent pacemakers. Data from the National Inpatient Sample between 2018 and 2021 were analyzed for patients who underwent leadless pacemaker implantation, using very specific inclusion and exclusion criteria. Patients were identified using ICD-10 codes and categorized into BMI groups, which included underweight, normal, overweight, obese, and morbidly obese. The primary outcome was in-hospital mortality. Secondary outcomes included blood transfusion, pericardial complications, infection and inflammation, removal, revision, and other complications. The study included 3,832 patients. The authors identified that compared to the normal weight group, those who were categorized as overweight, obese, and morbidly obese demonstrated a lower risk of in-hospital mortality compared to the normal weight group. Looking at the individual categories, the adjusted odds ratio for those overweight compared to normal was 0.432 with a p-value of 0.009. Comparing the obese group to the normal weight group, the odds ratio is 0.465. Also significant p-value, a p less than 0.001. Comparing the morbidly obese to the normal weight group, the adjusted odds ratio was 0.299, also significant. The authors conclude and summarize that these findings support the existence of the obesity paradox in patients with leadless permanent pacemaker implantation, where higher BMI categories are associated with improved mortality outcomes, meeting the pre-specified primary endpoint. The next paper also looks at BMI. The title of the paper is A Negative Relationship Between First-Pass Pulmonary Vein Isolation and Body Mass Index in Ablation Index-Guided Pulmonary Vein Isolation by Dr. Heidi Haru Okamatsu. The authors note that they previously reported the relationship between first-pass pulmonary vein isolation and pulmonary vein isolation durability in ablation index-guided AFib ablation. This was a paper in JCE of 2023. In the current study, the authors explore the impact of obesity on first-pass pulmonary vein isolation, as well as considering the impact of general anesthesia. They retrospectively studied 2,187 consecutive patients undergoing ablation for the first time. The majority of the patients had conscious sedation, 1,969, and general anesthesia was used in 218. The group was divided into 4 groups according to body mass index: underweight, normal, overweight, and obese. The authors identified that first-pass isolation rates decreased as BMI increased, both in those who had conscious sedation as well as general anesthesia. In the underweight patients, the first-pass isolation rate for those who received conscious sedation was 68%. In the patients with normal weight, 61.5%, overweight of 48.7%, and 39% for obesity. A very similar effect was seen in those who received general anesthesia. Multivariate analysis revealed that overweight and obesity as independent predictors of AF recurrence after first-pass isolation. Notably, the successful first-pass isolation rate in obese patients, even under general anesthesia, was low. The title of the next paper is High-Power Short-Duration Setting Prevents Changes of Periprocedural Thrombotic Markers and the Onset of Silent Stroke in Patients with Atrial Fibrillation by Dr. Masashi Kamioka and colleagues. The objective of this study was to investigate the clinical impact of high-power short-duration setting ablation on changes in periprocedural thrombotic markers and the onset of silent stroke. The authors enrolled 101 AF patients. The high-power short-duration group were 67 patients, used 50 watts, and the conventional ablation group, which was 34 patients, using 30 to 40 watts. D-dimer, thrombin antithrombin complex, or TAT, and total plasminogen activator inhibitor, or 1-TPA1, were analyzed. The day before the procedure, blood was drawn, as well as immediately after the procedure, 1 day after the procedure, and then in addition, magnetic resonance imaging was performed within 48 hours after the procedure. In the results, the authors note that the left atrial dwell time was significantly shorter in the high-power short-duration group. In the conventional ablation group, the D-dimer and TPA1 levels continued to increase until 1 day post-procedure, while the TAT peaked immediately after the ablation. On the other hand, the range of the variation of these thrombotic markers in the high-power short-duration group was smaller. Silent stroke occurred more frequently in the conventional ablation group than in the high-power short-duration group, which was 26% versus 5%, with a p-value less than 0.05. In the logistic regression analysis, the high-power short-duration setting and the thrombin-antithrombin complex difference between post-procedure and pre-procedure were independent predictors for silent stroke with an odds ratio of 0.14, p-value less than 0.05. The authors conclude that high-power short-duration setting led to a shorter left atrial dwell time and reduced change in thrombotic markers, resulting in a lower prevalence of silent stroke. The title of the next paper is Ventricular Tachycardia Ablation Across Age Groups, Outcomes, Trends, and Demographics, Insights from the National Inpatient Sample Base by Dr. Ramez Morcos and colleagues. The objective of this study was to investigate age-related trends in ventricular tachyarrhythmia ablation procedures and their associated adverse events across the United States from 2011 to 2021 using the National Inpatient Analysis of Adult Patients. The primary objective was to analyze ventricular tachycardia ablation outcomes by age groups, with secondary outcomes including sex and geographic region. The patients were divided into 3 age groups, equal to less than 59 years, 60 to 79 years, and equal to or greater than 80 years. The authors also perform a propensity score matching to control for confounders. The study included 95,913 VTA procedures. The mean age of patients undergoing VTA increased over time, with a growing proportion of procedures performed in older patients. Overall, adverse events did not significantly differ across the age groups. Mortality and hemorrhage were significantly higher, however, in patients equal to or greater than 80 years of age, and as expected, in-hospital mortality was highest in the equal to or greater than 80 years of age group, which was 5.1%, compared with 1.6% in the equal to or less than 59 years of age group and 2.7% in those between 60 and 79 years of age. Significant differences by sex and region were also observed. In 2011, 72% of VTAs were performed on males, with females comprising only 27.9%. By 2021, 76.4% of VTA was still carried out on males, while females accounted for only 23.6%. Throughout the decade, there was a statistically significant difference in the distribution of VTA between males and females. In terms of geographical differences, the southern United States consistently exhibited the highest proportion of VTAs, reaching 41.7% in 2020, dropping slightly to 36.6% in 2021. Conversely, the western region had the lowest proportion of VTAs, with numbers declining over the decade. In 2021, the VTA proportion was 17%, and these geographical variations were statistically different. The authors conclude that the overall incidence of adverse events with VTAs did not significantly increase with age. Specific severe outcomes, such as in-hospital mortality and hemorrhage, were, however, more prevalent in older patients. The authors suggest that these findings support that VTA can be safely performed across age groups, but caution and careful consideration is essential for elderly patients. The authors recommend that future research should focus on understanding the impact of age-related physiologic changes and comorbidities on VTA outcomes. The title of the next paper is Analysis of Junctional Beats During Slow Pathway Ablation, Illuminating the Mechanism of Typical and Atypical AV Nodal Reentrant Tachycardia by Dr. Fong Tan Yen. Background of this study that the authors notice that junctional rhythm frequently occurs during radiofrequency ablation procedures targeting the slow pathway for AV-NRT, and that signals successful ablation. Two types of junctional rhythms have been noted. One, typical junctional rhythm as His activation precedes atrial activation, and atypical junctional rhythm as atrial activation precedes the His activation. They posit that nevertheless, the origin and characteristics of junctional rhythms remain incompletely defined. Therefore, the objective of their study was to investigate whether junctional rhythms induced by RF ablation at the anatomical slow pathway position could reveal preferential conduction in the antegrade versus the retrograde direction. They included 40 patients undergoing AV-NRT ablation. They used standard electroanatomic mapping, the coronary sinus ostium, His bundle, radiofrequency sites, and noted the distances between these sites and the radiofrequency sites. The authors compared the HA and AH intervals during AV-NRT. The authors observed that in typical AV-NRT, the H to A interval during junctional rhythm resembled the H to A interval during AV-NRT with an identical atrial activation sequence, supporting junctional rhythm conduction to the atrium via fast pathway. The atypical AV-NRT group displayed a significantly shorter A to H interval during junctional rhythm than the A to H interval during AV-NRT with identical atrial activation. The junctional rhythm incidence in patients with both typical and atypical AV-NRT showed no correlation with the radiofrequency site location. The authors conclude that for patients with typical AV-NRT, junctional rhythm induced by slow pathway ablation preferentially followed the fast pathway. In patients with atypical AV-NRT and with retrograde slow pathway conduction, a shorter AH interval during junctional rhythm with the same atrial sequence as that observed during atypical AV-NRT implied retrograde conduction from the slow pathway to the atrium. In their key findings, they note that 1, the junctional rhythm induced by slow pathway heating tends to preferentially conduct to the fast pathway in patients with typical AV-NRT, whereas there is evidence of retrograde conduction from the slow pathway to the atrium in patients with atypical AVNRT. 2. The distinctions in conduction patterns provide valuable insights into the underlying mechanisms of typical and atypical AVNRT. And 3rd, the incidence of junctional rhythm did not correlate with the anatomical location of the radiofrequency site in patients with typical or atypical AVNRT. The title of the next paper is Validation, Bias Assessment, and Optimization of the Unified 2-Year Risk Prediction Model for Undiagnosed Atrial Fibrillation using National Electronic Health Data by Mohammed Ataya and colleagues. The background of this study is that prediction models for atrial fibrillation may enable earlier detection and guideline-directed treatment options. However, model bias may lead to inaccurate predictions and unintended consequences. The purpose of this study was therefore to validate, assess bias, and improve generalizability of the Unified 10 model, which is a 2-year, 10-variable predictive model of undiagnosed AF in a national data set, originally developed using the Indiana Network for Patient Care Regional Data. Unified 10 was validated and optimized using Optum de-identified electronic health record data set. AF diagnoses were recorded in the January 2018 to December 2019 period and designated as the outcome period, with January 2016 to December 2017 as the baseline period. Validation cohorts, that is patients with AF and non-AF controls aged equal to or greater than 40 years, comprised the full imbalanced and randomly selected balanced data sets. The authors looked at the model performance and bias in patient subpopulations based on sex, insurance, race, and region. Of the overall patients, 246,975, which is 4.1% of all eligible patients, had their first AF diagnosis within the outcome period. The validated Unified 10 model achieved a higher C statistic, 0.85, versus 0.81, and sensitivity, 86% versus 74%, but lower specificity, 66% versus 74%, than the original Unified 10 model. During retraining and optimization, the variables of insurance, shock, and albumin were excluded to address bias and improve generalizability. This generated an 8-variable model, or Unified 8, with consistent performance. The authors conclude that the Unified 10, developed using regional patient data, displayed consistent performance in a large national data set. Unified 8 is more parsimonious and generalizable for using advanced analytics for AF detection. The authors suggest that future directions include validation on additional data sets. The title of the next paper is Percutaneous Left Atrial Appendage Closure using a modified single-operator technician approach under deep sedation, a single-center experience. This is by Dr. Alejandro Jose Quiraz Alfaro and colleagues. The authors provide the following background. Historically, percutaneous transcatheter left atrial appendage closure has been performed under general anesthesia with transesophageal echocardiographic images obtained by a non-invasive cardiologist and usually requires an overnight hospital stay. In this study, authors present their single-center experience performing left atrial appendage occlusion devices under deep sedation using an echocardiographic technician instead of a non-invasive cardiologist and expediting same-day discharge. Outcomes included mid to long-term safety. Feasibility outcomes were also evaluated with follow-up imaging at a 45-day visit. A total of 150 patients with elevated CHA2DS2-VASc scores, a mean of 4 points, underwent TEE-guided left atrial appendage closure devices using the Watchman Flex from Boston Scientific. This was all performed under deep sedation. The mean age of the patients was 78, 51% were men, 98% had the device successfully implanted, and 97% were discharged on the same day. Only 9 patients, or 6%, required conversion from deep sedation to general anesthesia. Only 5 patients, or 4%, had complications during the procedure. None of the patients died or had complications from deep sedation. During the 45-day follow-up visit, one patient had a significant peri-device leak and another patient had device-related thrombosis. The key findings that the authors present is that number one, performing percutaneous left atrial appendage closure device with an approach involving same-day preoperative imaging and postoperative discharge could reduce costs and recovery time and increase the availability of the procedure to more medical centers. Second, deep sedation can be a safe alternative to general anesthesia when performing percutaneous left atrial appendage closures, potentially reducing the average hospital length of stay. And finally, as demonstrated, a properly trained technician can safely replace the role of a non-invasive cardiologist and operate the transesophageal echocardiographic probe under the guidance and supervision of the implanting physician, with an implant success rate comparable to the one reported nationwide between August 2020 and September 2022 in the United States. The next paper is titled Risk of Stroke with Reduced Dose Direct Oral Anticoagulants versus Standard Dose Anticoagulation After Cardioversion of Atrial Fibrillation, a Systematic Review and Meta-Analysis by Dr. Travis Kivilian and colleagues. The background to this study is that there is consensus on the safety of standard dose direct oral anticoagulants, or DOACs, for stroke prevention in patients undergoing cardioversion of AFib, but outcomes of reduced dose DOACs in this setting remain unclear. The purpose of this study was to perform a systematic review and meta-analysis aimed to compare the rate of cardioversion-associated thromboembolic events between patients taking reduced-dose DOACs and those receiving standard-dose anticoagulation. A systematic search was conducted for studies published between January 1, 2009 and February 16, 2024 in PubMed, Embase, and the Cochrane Central Register of Controlled Trials. The included studies compared the rate of thromboembolic events in patients with AF undergoing cardioversion on reduced-dose DOACs with the rate in those on standard-dose anticoagulation. Odds ratios were pooled with a random effects model. The authors found 2 randomized controlled trials and 8 cohort studies that met the indications. This included 5,212 patients with AF who underwent cardioversion on either full-dose or reduced-dose anticoagulation. Follow-up ranged from 3 hours to 90 days after cardioversion. The authors found that there was a numerically higher rate of thromboembolic events in patients undergoing cardioversion on reduced-dose DOACs than in those on standard-dose anticoagulation, which was 0.69 versus 0.29% with an odds ratio of 1.98. However, they found that the difference was not statistically significant. The authors conclude that their systematic review and meta-analysis suggests that there is a numerically higher risk of thromboembolic events in patients on reduced-dose DOACs compared to full-dose anticoagulation, but that the difference was not statistically significant, and that these findings raise concerns about the safety of reduced-dose DOACs in patients undergoing cardioversion. The next paper is a study design paper. The title of the paper is Use of Continuous Cardiac Monitoring to Assess the Influence of Atrial Fibrillation Burden and Patterns on Patient Symptoms and Healthcare Utilization, the DEFINE AF study by Dr. D.J. Laccaretti and colleagues. The background of this study is that the relationship of AF burden and temporal patterns of AF on patient symptoms, outcomes, and healthcare utilization is unknown. Insertable cardiac monitors are a strategic and as yet untapped tool to investigate these relationships. The objective of the DEFINE Atrial Fibrillation study will evaluate how AF burden and patterns are associated with changes in AF-related healthcare utilization and patient-reported quality of life. This is a prospective observational multicenter study that addresses AF as a multifactorial disease. Patients with AF implanted with an insertable cardiac monitor will be enrolled in the study and managed through the app-based research platform on their smartphone. Patients will then be remotely monitored, and patient-reported outcomes will be collected via the app. AF-related healthcare utilization will be confirmed via the participant's medical record. The primary analysis will evaluate whether summary and episodic measurements collected by the ICMs are associated with changes in AF-related healthcare utilization, and secondary analyses will determine the relationship between AF characteristics and quality of life, timing and severity of AF-related complications, patient engagement, reliability of patient-reported outcomes, data from other digital rhythm detectors, and heterogeneity in care quality and AF-related healthcare utilization. Well, we wish the authors the best in performing this trial, and we look forward to the conclusion of this study and the presentation and publication of the data. The next paper is a case report. The title of the paper is Right Anterolateral Abdominal Wall Hematoma Following a Concealed Left Anterolateral Accessory Pathway Ablation by Dr. Salah Alawani and colleagues. This case is a 31-year-old otherwise healthy woman who underwent an ablation for an SVT. She had no significant medical problems. Conscious sedation was used and right femoral access. Appropriate intra-op heparin with ACT of 300 to 350 seconds was used. The authors identified an anterolateral accessory pathway which was successfully performed and the patient discharged without any complications out of the EP lab. Later, however, the patient had an anterolateral abdominal wall hematoma form from inadvertent puncture of the inferior epigastric artery, which is a branch of the femoral artery. They go on to discuss the patient management and the anatomy of this complication. Next up is a brief report. The title is Atrial Fibrillation Catheter Ablation Decreases the Duration of Antiarrhythmic Drug Therapy for United States Active Duty Military Personnel. This report compares patients who had a strategy of receiving early catheter ablation compared to just continuing them on antiarrhythmic drugs. The primary finding was that the duration of having to be on an antiarrhythmic drug was significantly shortened by the opportunity to have an AF ablation. The key findings of the study are, first, that catheter ablation for AF and military personnel significantly reduces the treatment duration of antiarrhythmic drug therapy. Second, most military personnel receive Class 1C antiarrhythmic drugs, followed by Class 3 antiarrhythmic drugs. And third, it is reasonable to consider AFib ablation in these patients with tactical athletic occupations not amenable to chronic antiarrhythmic drug therapy. Well, that is the end of our December 2024 issue and finishes up this podcast, and in fact is the end of year 2024. Next month, we'll be out with our first 2025 January podcast. I look forward to summarizing that issue for you next month. Happy holidays and Happy New Year.